Hi, everyone, and thank you for the invitation. It's nice to see colleagues outside of things like committee work and so forth. So happy to be here. I was explaining that I don't have a PowerPoint. I prefer to speak, and so I've got my talk written up and I'll read, but hopefully not in a monotonous and boring way. My talk today is about access to COVID-19 technologies. There's a lot of focus on vaccines, and it's based on work I've been doing partly at UCT and partly as a member of the People's Health Movement, which is a civil society organization that's works to realize the right to health for all. And so needless to say, in the context of the pandemic, a lot of that work has focused on access to COVID diagnostics, vaccines, and therapeutics. And, you know, I'd like to start the talk with a quote by one of the founders of PHM. His name was Amit Singh Gupta, and he, at the last health assembly that PHM held, he made this remark, which I think is quite significant. He said, the struggle for health is the struggle for a more caring world. And so that's kind of informed my thinking in doing this talk. I also think it's significant because COVID, as we know, emerges in 2019. And at the start of 2020, one of the big annual events on the global calendar, the World Economic Forum, is held in Davos, Switzerland. And it's at Davos where Oxfam in 2020 launches its Time to Care report. And this report focuses on the economic value of unpaid care work, unpaid social reproduction work. And so the report makes many different points. One of them is that, you know, unpaid care work contributes about 10.8 trillion annually to the global economy. And of course, it's not typically costed. So the figure seems quite shocking. And the point of raising this at Davos is that Oxfam is trying to advocate for kind of restructuring recognition of how we recognize social reproduction work in monetary terms. The great irony, of course, is that this report is introduced in the very same year that globally most states rely on unpaid social reproduction work, most of it done by women, to manage the fallout of the COVID-19 pandemic. So not only job losses and so forth, but caring for the sick at home during lockdowns and so forth. The other significant thing that happens at Davos in 2020 is something that I'll focus on in this talk, and that's the creation of a facility, a purchasing facility called COVAX. It's a kind of global public health partnership, or what we might call in the domestic sphere, a PPP, a public-private partnership. And COVAX is created to create a market for purchases of vaccines, COVID-19 vaccines. And I'll say a little bit more about COVAX, but it basically is created to take a risk away from vaccine developers and to guarantee them a market for COVID-19 vaccine purchasing. And also the idea is that it will be a single procurement mechanism that serves the global economy, that serves all countries and ensures that everyone globally is able to vaccinate at least 20% of their population. And the ideal is that this would be frontline workers and the elderly. So both of these events occur at Davos. And I'll say a little bit more about why Davos is important in the context of the epidemic and the conceptions of kind of salvation and personhood that I think it has revealed. So I'm not a historian, so that's kind of one caveat from my end. And that said, I'm gonna dive into the talk. So a couple of weeks ago, I visited a local retailer called Mr. Price. And I was quite excited about what I had bought, so I didn't pay much attention to the bag, the packaging. And it was only a few weeks later that I noticed that the bag said something. It had a message printed in bold that was quite, I think, an accurate description of how the pandemic's been managed by big pharmaceutical companies. And so that message was, it was love at first price. And this really strikes me as a slogan for our pandemic times. In preparing for the talk, I read several interviews with the Pfizer CEO, Albert Bourla. And many of these interviews, he emphasizes both the fact that Pfizer has tried to make vaccines affordable, but also there's a lot of emphasis on emphasizing the competitiveness of the company and the shareholder value that this new vaccine brings to the company. Bourla himself has received about 24.3 billion in compensation for his performance only during 2021. So in terms of profit making, the numbers are astronomical, and that's not only the case for Pfizer, of course, but also for other companies like Moderna and AstraZeneca. And then, of course, more, I think disturbingly, there are other big numbers that we need to take cognizance of. So The Economist estimates that as of mid-April, excess deaths due to the COVID pandemic stood at 20.6 million globally. So this is in sharp contrast to the official COVID death toll, which is only around 6.2 million people globally. And of course, that bigger figure of almost 21 million people is a reflection of the fact that the excess deaths associated with the pandemic would not only be due to COVID, but due to the impacts that COVID has had on the economy and also more narrowly the health system and access to health services. So we have these huge numbers, but let's also think about smaller numbers. So also as of mid-April, Africa CDC reported that only about just under 16% of the continent is fully vaccinated. And this is in sharp contrast with high-income countries like the UK, where about 73% of the population is fully vaccinated. Germany also is at about 76%, and Switzerland around 70%. And so I named these countries, many of which also have booster doses administered to over 60% of the population, because these are the countries, together with the European Commission more broadly, that are blocking a proposal tabled by South Africa and India at the World Trade Organization in October 2020. And this is a proposal that's supported by over 100 countries at the World Trade Organization. And the proposal is that all intellectual property rights on COVID diagnostics, vaccines, and therapeutics be waived. And so it's ironic that countries that have such high vaccination rates have been instrumental in blocking equitable access to vaccination in the global South generally, but also, I think, in particular on the African continent. So together with major pharmaceutical companies like Pfizer, Moderna, AstraZeneca, these countries have argued that intellectual property rights are not an obstacle to ensuring equitable access to COVID-19 technologies. And instead, they've insisted that fair pricing is a key mechanism for ensuring equity and access. So in what follows in this talk, I want to highlight the different ways in which people have spoken about the importance of intellectual property rights, pricing, and equity in the context of the pandemic. And I'm interested in this idea or this concept of fair pricing because I think it serves as a kind of lens or a focal point for thinking more widely about how we speak about market failures and relations of domination as they are manifested in the global political economy. So when I say I'm interested in how people speak about this, I'm following J.B. Thompson and his insight that language conveys meaning, and of course meaning serves to establish and sustain relations of domination. So I think J.B. Thompson's work is interesting because it encourages us to look at the ways in which meaning is used by hegemonic individuals and groups in order to establish and maintain social relations from which they benefit, but at the expense of other individuals and groups. So if that's the entry point, what is the meaning of having a conversation about pricing being fair in the context of 20 million deaths and counting? And what does it mean to speak of vaccines as a public good in the context of a legal system that gives private corporations discretionary power over access to life-saving medications? And then finally, how is it possible to reconcile this reality with the ongoing rhetoric about respect for human rights and all life being valued equally, that often comes out of multilateral institutions. So those are the questions that I'm broadly interested in exploring, and this is very much a draft paper, and so some bits and pieces might be a little bit unfinished. But for now, back to Mr. Bola of Pfizer. So in a letter that the Pfizer CEO posted on LinkedIn in May 2021, he writes that, quote, fair and equitable distribution of vaccines was Pfizer's North Star from day one, end quote. And then he says that to achieve this, the company adopted a tiered pricing strategy whereby, quote, wealthier nations would have to pay in the range of about the cost of a takeaway meal. Middle-income countries were offered doses at roughly half that price, and low-income countries were offered doses at cost, close quote. He then goes on to acknowledge that this resulted in an oversupply of vaccines in the global north relative to the south. And he notes that this is something he tried to address by, quote, reaching out to many heads of middle and low-income countries by letter, phone, and even text to urge them to reserve doses because the supply was limited, end quote. He makes no mention of the fact that LMIC governments were offered tiered prices. But in addition to this, they were also asked to use sovereign assets as guarantees against future legal cases stemming from vaccine-related injuries. So, for example, there were press reports that in the case of Argentina, Brazil, and South Africa, federal reserves, embassy buildings, and military bases were identified as examples of collateral demanded by the company. So this is placed outside of the fair pricing framework, as it were. And so certainly tiered pricing seems to be thought of by the company as eliciting something like love at first price in relation to their vaccines. So this, I think to some extent was countered by some public power that was exercised, or public pressure that was exercised on Pfizer and other vaccine companies. So I think most dramatically, global South countries pushed back against the demands that sovereign assets be used as collateral for procurement of vaccines. But other pressures also surfaced related to intellectual property rights and also the structure of the procurement market during the COVID crisis. So in relation to intellectual property rights, for example, in February 2021, Pfizer readily acknowledged in an investor call that they were forced to adopt so-called pandemic pricing. And this was because they were operating in a context where intellectual property rights were being threatened by the TRIPS waiver. And governments wanted, particularly governments of the global South, wanted to use the waiver to transfer know-how and technology to regional production hubs so that these could address the artificial shortages created by IP monopolies. So governments of the global South saw this as an essential intervention to overcome inequitable vaccine access. And of course, this stems from pharma companies' legal entitlements under international law to exclusively decide who's able to manufacture vaccines and how and when they should be sold and distributed. But there's also a second form of public power that was exerted by governments, and in this instance, it was in their guise as buyers of vaccines. So on the same investor call I mentioned earlier, Pfizer management acknowledges that they are not operating in what they call, quote, an open market, at least not for this year. This year, it's a market that's controlled by governments because we're in a crisis, end quote. So they note that this means that the company is only securing about a 20% profit margin on drugs, and that it intends to go back to normal pricing once the pandemic pricing environment comes to an end. And so, they make this, this reference to charging about $20 per dose during this pandemic pricing period, but being able, they hope, to charge about $150 to $175 a dose once they're in what they call a normal pricing environment. So that would be a profit margin of closer to 50 to 60%. So it's worth noting that this market-based approach to talking about medical products and particularly the focus on the presumed ethical quality of tiered pricing is something which first emerged in the context of campaigns for access to antiretroviral medication. So the ARV struggles, I would argue, is one way to look at it is that it's a moment where this market logic for talking about fair markets, equitable markets for access to essential medicines enters into global health governance discourse and becomes normalized. So during the HIV/AIDS pandemic, literally decades of political activism shamed pharmaceutical companies and governments in the North into offering discounted prices for ARVs in the global South, and also to relax intellectual property rights restrictions to allow for the manufacturing of generics. So it's significant, I think, that these decisions were not taken at the risk of completely forfeiting profits. Rather, the presence of institutional buyers and the nature of ARVs as chronic medications provided Big Pharma with profitable and fairly low risk incentives to allow ARV prices and concessions also on IPR, intellectual property rights. At the time, the emergence of large new institutional buyers like the US PEPFAR program, but also the Global Fund, also helped to create sustainable long-term markets for lower cost ARVs. And this was particularly the case in Africa. And so these markets created through purchasing programs served to increase access to treatment. And this was, of course, very, very valuable. At the same time, the strategy came into being because it was part and parcel of a shift towards a kind of health securitization discourse that emphasized the risk that HIV/AIDS posed in the global North. And at the time, the creation of these markets for essential medicines in the South, for example, through PEPFAR, was aimed at creating these serious security issues. So, for example, the Section 10 of the PEPFAR Act, the act that creates this public procurement mechanism in the US for ARVs to be sent to the global South, particularly Africa. Section 10 enumerates some of the risks as the potential for political instability, economic devastation, destabilization of agricultural production globally, but also, for example, decreasing the ability of global North countries to resolve conflicts abroad through peacekeeping operations because of their troops risking exposure to HIV and potentially their troops exposing local communities to HIV/AIDS. So during the same period, I argue the logic of creating markets or making markets gained further traction through the work of philanthrocapitalists organizations like the Bill and Melinda Gates Foundation and the Clinton Health Access Initiative. So these foundations entered the global health governance ecosystem and consolidated their power as important stakeholders, first in the context of HIV/AIDS, but later on they continued, particularly the Bill and Melinda Gates Foundation, continued to exercise a major influence through global public health partnerships like CEPI and Gavi, which are two organizations that are now involved in creating pre-purchasing commitments for COVID-19 vaccination. So they helped to establish COVAX, and CEPI and Gavi have experience in this area because CEPI is an organization aimed at facilitating epidemic preparedness responses, and Gavi is an organization that has been created in order to create a more stable market for the purchasing of childhood vaccinations for use in the global South. So both of these organizations are aimed at kind of de-risking the procurement of essential and also new medical technologies. And by de-risking, I mean the risk that pharmaceutical companies face in terms of making products, but not being able to have a market to sell them. And so Felix Stein, who writes about COVAX, says that one of the things COVAX does in creating these markets for pre-purchasing new technologies like COVID-19 vaccines is it conflates public health risks, so the risks associated with the pandemic, with the corporate risks faced by pharmaceutical companies that bring new products to market. So I think that's one of the things that's worth noting. So, of course, all of this, or much of this infrastructure that's aimed at making markets and specifically making markets work so-called for the global south and poorer people in the global south becomes possible through the emergence of philanthrocapitalism. And so McGoey points out that, quote, the idea that to do good socially, one must do well financially, end quote, underpins philanthrocapitalism. In other words, quote, public and private interests are strategically conflated and touted as intrinsically mutually compatible, end quote. She goes on to argue that, quote, the conflation of public and private interests resonates with 18th century conceptions of the moral value of capitalism, the debatable view that capitalism helps to mitigate political strife and foster cooperation amongst nations, promoting the public good through individual economic enrichment, end quote. So the kind of work that Albert Hirschman did, for example, on this. So this approach to health equity, this philanthrocapitalist approach to health equity, which frames financing and private capital as keystones of health and global health governance, is captured in a speech delivered by Bill Gates at the 2005 World Health Assembly. So in this speech, quote, he argues, quote, that the world didn't have to eliminate poverty in order to eliminate smallpox. And we don't have to eliminate poverty before we reduce malaria. We do need to produce and deliver a vaccine. To find new discoveries and deliver them, we need to make political and market forces work better for the world's poorest people. We have a model in the Global Alliance for Vaccines and Immunization, Gavi. When that project began, vaccines were sitting on the shelf as kids were dying from these very diseases. Other necessary vaccines were not being manufactured at all. The market wasn't working to bring people what they needed because there wasn't enough money to create a demand and guarantee a supply, end quote. So it's interesting to me, just to link back to Thompson and the use of language for the purposes of serving hegemonic interests. What's interesting to me about Gates's intervention, but also interventions like COVAX, for example, is the fact that they stem from quite explicit acknowledgements of market failures in the area of access to essential medicines. But at the same time as this market failure is acknowledged, there's a kind of redoubling of a commitment to the market as a mechanism that can still be salvaged, still be utilized in order to guarantee equity. And so this, I think, is a troubling aspect of the discourse around fair pricing and making markets work for the poor. So what does this mean if we think about this more carefully? So Gates, but also the pharmaceutical companies that are producing COVID-19 technologies, seem to be talking about an approach to health equity, I think, that is essentially market and technology based. So the struggle for health here, I think, is conflated with the struggle to correct market failures. And on this understanding, correcting market failures is how one demonstrates care and also regard for those without the financial resources to, quote unquote, count in the market. Or as Gates puts it in the 2005 speech I just read from, quote, citizens around the world should petition their governments to put up money to make market forces work better for the world's poorest people, end quote. So it's this logic, I'd argue, that has led to inequalities that the COVID pandemic has exposed, but not created. The prominence attached to fair pricing in these discourses differs and obscures conversations about power inequalities in the global political economy. It focuses our attention on the quality of pricing. So is it fair? Is the pricing fair? Not on the character of decision makers. So is this process democratic? Is it subject to national government's oversight? Are people able to say what they need, when they need, and how they need it? And I think in doing so, we're focusing on this question of fair pricing. The debate forecloses questions about whether we're using the right concepts and the right language to realize this ultimate goal of making a more caring world. If the struggle for health is the struggle for a more caring world, will we realize this aim by using the language of markets, consumers, and self-sufficiency in manufacturing? Or should we be using a different register? So should we instead be concerned about what we are doing and what that means for achieving personhood, community, and what in South America is often referred to as buen vivir or good living. Why do I refer to achieving personhood rather than human rights, which has perhaps been the dominant progressive discourse in the post-World War II period? One reason for this is to highlight the point made by Weredu and others, African philosophers specifically, that personhood is achieved. And while human rights, such as the rights to food, bodily integrity, and health, may be sufficient for securing life itself, I would argue they are not sufficient for achieving personhood in the sense of personhood as an ongoing process of becoming. So the conversations around price and making markets seem to me to reflect a larger and long-standing concern with bodily survival or welfare, and specifically with the role of post-Enlightenment scientific knowledge in securing physical vitality or life itself. And because of this focus on technological interventions, so remember Gates's comment that we didn't need to eliminate poverty to eliminate smallpox. It's not necessarily, this conversation is not necessarily connected to a larger political project centered on social relations and at building the kind of global community in which this ongoing process of achieving personhood can and should be achieved as a matter of priority. So I'm going to try and wrap up because I see we're at past. But so a couple of closing observations. I think for me, perhaps this is why the conversation around fair pricing and making markets is so dangerous, because it risks locating us in a conversation that is suffused with what Maldonado Torres calls the coloniality of power, knowledge, and being. And in this, it's a conversation where technological solutions and efficiencies are centered. There's no denying that these interventions are important, but I would argue that they aren't enough to ensure that, in the words of President Ramaphosa, quote, we accelerate our collective efforts to ensure that vaccines become a global public good and are made accessible to all countries in the shortest possible time, end quote. And I think as maybe a provocation in a room full of historians, I think one of the ways to ensure this is to perhaps return to old imaginaries of transforming the global order. And so one of the ways that we might think about doing this is to revisit some of the post-independence thinking, particularly as articulated in the political project of third worldism. So I take my conception of third worldism from Andrew Nash, who describes it as a significantly flawed political project, but nonetheless as a viable model, as viable a model as we have, and here I'm quoting him, of a revolutionary internationalism as a living force, an ethos of consciously shaping ideas and actions, not through pronouncements from above, but through building links of solidarity, exchanging ideas, developing common resources, and engaging in collective action. And of course, two of the key texts that this was kind of thought through, that helped to think through this agenda would be the Declaration for a New International Economic Order and the Alma-Ata Declaration on Primary Healthcare, both emerging in the 1970s. So I think one of the reasons why these formulations, the formulations particularly in Alma-Ata around maintaining that people should have the right and duty to participate individually and collectively in the planning and implementation of healthcare, one of the reasons why that's striking is because there's an emphasis on health as something that's contingent on transforming broader power relations. So poverty isn't read out of the conversation, it's in fact part and parcel of the problem. But also this idea that the more kind of technical or direct solutions or interventions in the sphere of health governance should not be subject only to kind of technical decision-making procedures, but also through processes of consultation and engagement with the patients, the communities that are at the receiving end of those health technologies. And so I think when we ground arguments for equitable access to healthcare in a financialized language, this element is lost, and I think it can prove dangerous because the problem to be addressed becomes one of efficiency and delivery and not really understanding how people experience events like pandemics and a lack of access to healthcare in the context of pandemics. And I think when we speak in the register of efficiency and financialized solutions, the forms of being human that are rendered visible or most legible by these conversations emphasize the primacy of the rights of a universal subject. And perhaps because we're operating in the sphere of health, it's not a disembodied subject, but it's certainly an individual subject, and it exists, I think, at a remove from its collective element and conversations about radical political agency. And I think when this more collective element is read out of the frame, it obscures what one medical doctor, Che Guevara, framed as the ultimate and most revolutionary aspiration, which is to see human beings liberated from their alienation. So, for example, focusing on localization of production of medicines as purely a matter of achieving similar levels of national control and political sovereignty to more dominant states in the global system means, I think, that we risk losing sight of something that Fanon describes as the need to break up the colonial world rather than to seek to join it on the basis of equality. And so I think this is something that, as I said before, gets read, this injunction for political agency, the nature of political agency as a collective act. This is something that gets read out of the frame when we think purely of equity in terms of market-based or financialized solutions. And I think this is something that even in global South governments advocating for something like the TRIPS waiver, suspension of intellectual property rights as necessary for equitable access to medicines, it's a kind of latent danger that's in that discourse, because I think just as an emphasis on fair pricing risks depoliticizing issues of equity and access to healthcare, also this conversation around localization of production in the South has perhaps a similar kind of depoliticizing aspect to it. And so I would say it's in that context that this idea that third worldism as an internationalist project focused on North-South solidarities and in reading structural impediments to equity like poverty back into the frame might be an important resource, might be an important kind of site of thought to revisit in thinking about equity, not just in the context of the COVID-19 pandemic, but also future pandemics. So I'm going to leave it there and then I'll hand over to.
Thank you, Lauren. Thank you for the fascinating paper. We have, and sticking to time, 1:35, that's it. We have a good 20-25 minutes for discussion. I know some of our colleagues have a tight schedule at class to teach at 2. So without further delay, let me just open up the floor to questions and comments. Just if you can just turn on your video or use the hand tool or just whatever you feel comfortable with. Questions and comments for Lauren. I don't know if my side is, I can't see any hands right now, but if you can just, you don't need to use the hand tool. You can go, okay, I will start the ball rolling. I think people are still processing the talk. Thank you for the paper, Lauren. There's much to think about. I'm just thinking about what I'm going to begin with what you finished with. I'm just curious about what, if you could tell us a little more about what you're thinking concretely or around the third worldism in terms of health equity concerns, and how would we imagine, even begin to imagine that shape of things to come. Because you use the global south category, and I understand that's coming from the literature quite a bit, especially the way the TRIPS conversation allows us to tap into a global south very strategically and necessarily. But the global south in itself is riven with dissensions and riven with different kinds of majoritarianism, different kinds of chauvinism, and different kinds of access to healthcare, and with creaking healthcare systems which more and more are oriented towards health as a market, and have actually moved away from the TRIPS conversation. Apart from TRIPS, have moved away from equitable health to a large degree. And I know South Asia is that's very clear, and I'm sure I won't be very mistaken if that's not the general trend across different locations in the global South. So my question kind of emerges from that, that when I know you are thinking, you are actually urging us to think of a third worldism. I'm also trying to imagine what that would look like if we critically engage with the category of global south itself as far as health equity is concerned, because that's, apart from outside the immediate vaccine mandate, the market of health is something which is very neoliberal, for lack of a better word, in most global south locations. So maybe I don't know if that makes sense, but maybe we can start with that.
Yeah, so I mean, I wouldn't disagree with all of the complications that you've described in relation to this idea of a global south. So when I use the concept, I think of Vijay Prashad's definition of a global south as kind of a broad coalition of very diverse movements that have their own internal contradictions in terms of hierarchies and various forms of, I guess, domination, right? But that have a common thread that ties them together, which is a critique of neoliberalism, neoliberal globalization, you would say. So I think that's a resource for thinking through what's possible. The difficulty with that is that there's no one solution. I think the difficulty and the value is that there's no one solution, right, to what local forms of resistance will look like. And I think also that connects to the declaration of Alma-Ata. So what does it look like concretely? It will take diverse forms, but I think the common reference point is one that there needs to be a rethinking of the fact that the global political economy is configured in such a way. So, for example, in much of the South, configured around extractivist still economic practices that actively harm health, right? So, one kind of practical reference point in terms of Alma-Ata is then that we need broader systemic reforms that address modes of development that create adverse health outcomes. I think another kind of, and this again, Alma-Ata serves as a reference point, is that we need, Fran Baum and others wrote this article a couple of years ago on what they call social vaccines. So their argument is that we need to really emphasize the fact that people need institutions and processes that allow for the expansion of popular power and popular decision-making power. Actually a seat at the table to decide at the very local level, but also national and global level, to have a stake in health governance processes and in contributing to decisions around the policies and processes that affect them. So I think that's another kind of concrete, I mean, it's not very precise, but that's another kind of concrete outcome, right? And then the third thing I think is, and this is related to the second is that we have seen with the emergence of big philanthrocapitalist organizations that have amassed huge amounts of money, partly, for example, in the case of the Bill and Melinda Gates Foundation, that's not disconnected from the story of neoliberalism and the kinds of tax breaks that big corporations have been granted. So I think a third part in terms of the democratic decision-making space that we need to look at is to roll back the presence that these unelected bodies have, and they have huge influence in decisions over global health governance. So the kinds of contributions that institutions like the Gates Foundation makes to, for example, the World Health Organization, allows them to also influence decisions on which policy priorities WHO takes on in any particular financial year. So I think, and to tie this back to the question about third worldism, I think one of the things that is valuable about third worldism politically is that there's very much a commitment to multilateralism. So how functional or dysfunctional the multilateral system is another story. But I do think that immediate post-World War II period gives us a multilateral system in which governments are the major actors in decisions around health governance. I think with the emergence of philanthrocapitalist organizations and the major contributions they make to health budgets of UN institutions, including WHO, but not only philanthrocapitalist organizations, also big corporations, for-profit corporations, that the decision-making space allowed for unelected institutions, if you want to put it that way, has expanded massively. And nation states, which technically should be the key decision makers, and which in principle, citizens have control over, that has been rolled back, right? So this way, and again, I mean, technically in a multilateral system, the numbers that so-called global South states have in organizations like WHO, where it's one state, one vote, that this could give them a strategic advantage in the decision-making processes. And that's discounted, I think, when agendas arrive at the table pre-set and predetermined, partly due to the influence of kind of a multi-stakeholder model that marginalizes governments.
Thank you, Lauren. I have Adam had a question. I don't know. He's having some problem with background noise. I don't know.
Just serious building working in the background. That's why I asked it remotely. But you've actually, Lauren, you've largely actually answered my question in response to Anandrup's as well.
Okay, great. I think he was inquiring about state-led initiatives. Okay, I think we dwindle. Yeah, sorry, Lauren. Yeah, go ahead.
Maybe just on the state-led initiatives. I mean, I think one of the things also in terms of, so Anandrup, you pointed out that there is this kind of dominance of neoliberal discourse, right? And I think one of the things that's interesting about this pandemic is that it actually shows the value of state-led initiatives in terms of research and development. So masses of public money, particularly in the US, went into developing COVID-19 vaccines. And so I think, again, this is a kind of a reference point in terms of showing that states can be efficacious, if you want to use that language, in terms of subsidizing the development of essential medicines and bringing them to market. But the irony, of course, is that as a next step, then issues of ownership, for example, are not challenged. And so IP rights confer ownership almost exclusively, at least until very recently. For example, in the case of Moderna, those IP rights go to the corporations and not necessarily to public entities that could then, for example, extend licenses if they had a co-ownership in the IP. So I think that's an example of the public sector actually being functional, but the discourse kind of obscuring that potentiality as a lesson for future pandemics.
Sean Bodhi, the questions
I
gone.
was just thinking,
Yeah.
sorry,
Yeah.
Lauren, I was just thinking, I'm kind of processing your talk and your response, and I'm thinking, you raised the question of personhood, right? But in a certain sense, all these, and the last instance you mentioned about Moderna and the corporations hogging the licenses and the privileges and the IP rights. So there's another story of artificial personhood being made, right? I mean, which is kind of, which also has a equally long history with kind of modern subjectivity, which you are trying to foreground that experiences. But it's a subject which doesn't experience, but which absolutely holds the rights and duties apparatus in theory. And if we then, what I'm trying to, it's not really a question. What I'm trying to kind of understand and would like to hear your thoughts around what happens when we begin to take these two discourses of personhood together and somehow, a kind of a notion of personhood that is focused on experience and a kind of notion of personhood which has increasing access to the discourse of rights and privileges and so on. Right? I mean, I'm just trying to think that, to me it seems, and I absolutely in political agreement with you, but I'm also kind of trying to think that if there is a non-humanist ground from which this argument about neoliberalism, entanglement, and kind of a non-humanist ground from which to approach this question in theory, that's what I'm trying to understand. Because in a certain sense where you are, because I'm slightly concerned about one particular aspect of the political implication of the argument, which kind of, I think, indirectly was raised by Anandarup when he asked the question about the putative uniformity of the global South, because often these kind of reactivating the state machinery has actually, in many parts of the global South, it has actually entrenched the state's overlap with the corporations, right? So in a way, it has exposed the limits of an kind of, continuing an old welfareist argument in the current situation when the state is almost kind of besieged and partly owned by the corporations. So I'm just trying to think that what other ways of reformulating this argument are possible. Sorry, it's not a question, it's just a bunch of jumbled thoughts, but I'm just trying to think if there's enough theoretical grounds to make a different kind of argument, taking actually the question of personhood more centrally and not trying to put a kind of bodily personhood as the normative center of personhood. If that makes any sense at all, I don't. Sorry, but very interesting take. Thanks.
No, it makes sense. And I think, so probably I'll respond with my own jumble of thoughts. So I think what I was trying to speak about when I spoke about personhood was exactly not this idea of bodily personhood, right? So this idea that to be a person, so how I think about it is to be a person is to be a part of certain institutions, to be engaged in particular modes of conduct that are valued because they exist as demonstrations of solidarity with others that might be different to you, but that you're in alignment with in terms of certain normative or ethical commitments, right? So personhood as a practice of being in community, of communing. And so it's not something that's achieved solely by being alive. It's actually a praxis, right? And one that's ethically informed. So I think this is different from, and so because of that relational quality, there's a big, I think in this conception of personhood, there's a big emphasis on obligations and mutual obligations of care and so forth, right? Which I think is very different from if we think of corporations and a kind of legal argument of individuality. So I would see something like an individual with rights and entitlements, preformed and pre-existing. That's not necessarily equivalent to the process of achieving personhood. so that's one way in which I think of it. The other way in which I think this idea, so I agree with you that I think Ananda referred to it as chauvinism, right? So the chauvinism of states, and also preoccupations around purity and managing populations rather than necessarily being involved in governance. I think one of the that is not something that was absent, I think, during the post-independence period, the Third Worldist period. One of the reasons why I think strategically Third Worldism, and I used Andrew Nash's definition. So I think one reason why it's strategic is there is this kind of space in multilateral institutions for governments to propose solutions that have perhaps some capacity to counter the power of corporations, right? I don't think that's necessarily going to come from global North governments. I think because of how they're positioned in the global political economy, that's one kind of potentiality that's more likely to be associated with global South governments. But the other aspect of, and that's not necessarily something Andrew Nash speaks about in his, that's the kind of more conventional conception of Third Worldism as a government-led project. But I think the reason why I like Nash's conception of Third Worldism is because he focuses in his definition on populist struggles and North-South alliances. And he's not focusing on, so he uses this word solidarity and struggle. And that strikes me because that to me seems to be very much focusing on how people, for want of a better word, at the grassroots level articulate their own concerns. And it's not necessarily about rights or entitlements or needs, it's about a process of struggle, right? And therefore a critique against, or a critique of the constraints that they find impinging on their own lives. And so solidarities of struggle, and particularly North-South solidarities, and the categories are loaded, right? So, I mean,
sure. Yeah.
Be that as it may, but I like that idea of Third Worldism as a kind of grassroots internationalism. I mean, that's my rephrasing. And so I think that's why I use it here. And I think in that process of solidarity and mutual struggle, there is a kind of recognition of personhood that's absent, I think, in discourses that emphasize individual rights and entitlements, as if people are fully formed and always automatically recognized as people and as human beings in their fullness.
Thank you.
Thanks, Lauren. That's very useful. Sean, I don't know if you have a question.
I have a kind of, I don't know, I'm just curious to know, Lauren, thanks for the paper, but there's different ways to frame it, but I'm fascinated by the incurable. And I'm struck by how citizens and patients and various role players in any nation state want solutions. And that's what governance is supposed to provide solutions. But the reality is there's so many forms of incurable, like, and I'm very conscious, think often about how Ramaphosa's terrain of office is how his cabinet has responded to coronavirus pandemic is partly accentuated. They don't want to make the same mistakes as the Mbeki government made about HIV and AIDS. But the reality is that every nation state, whether you north or south, have to find ways of governing while there's multiple forms of incurable conditions operating. The reality is the HIV/AIDS pandemic has not gone away. It's still very real. I was just curious to know your thoughts about the incurable dimensions and how you.
Thanks, Sean.
Sorry.
Thanks, Sean.
No, I mean, so I don't know that I have a direct response to it, and I agree with you that there is this. So one of the things, let me put it this way, one of the things that fascinated me about the HIV/AIDS treatment debates was that this idea emerged, which was really important in making ARVs available in the South, this idea of a resource-poor setting, right? So when ARVs were first demanded, the response from many quarters was that it wouldn't work in the South. The clinic infrastructure was too poor. People didn't really understand how these medicines worked. So basically poverty is an impediment to this sophisticated technology doing what it should do. And then also, objections around this is something that's very specialized. It has to be tailored to the individual patient. So you can't have a massive public health program that just has a uniform protocol. And then I think, through clinical trials and so forth, activism, social mobilization, activists demonstrated that, well, actually you can have a standardized protocol. It's very effective. And you can have ARVs administered at clinic level. You don't need a sophisticated monitoring infrastructure. So I think what happens in this process is this idea emerges that you can have a technology in a resource-poor setting, right? And I suppose I'm thinking of this because I think this idea of a resource-poor setting then becomes a kind of incurable. So I guess what I'm saying is that there are many kinds of incurable, and so disease is one of them, but like these other things like systemic poverty, that becomes something that's an incurable, and so it exists as part of a supporting infrastructure for a particular kind of approach to public health management. And then the question becomes, okay, so how does that defer conversations about how we really promote health? So if the legal definition is that the right to health includes more than simply the absence of disease, then surely this other incurable of a resource-poor setting is something that we also need to address, because it actually undermines this idea that health is more than the absence of disease. And so, yeah, I mean, I agree with you that there are many, many incurables, and people kind of strategically read them out of the frame in order to make certain technologies seem, I think, usable, functional, etc., feasible. And I think partly that's sometimes a result of political pressures of the moment.
Thanks for the response, Lauren.
Thank you, Lauren. Thank you for a fascinating hour, which we are at the end of. And again, thank you for sharing your work. Apologies for the turnout. I think the long weekend has still lingering in the university atmosphere. But if you are okay with it, we can upload it. Thanks. Okay, and maybe it will have a larger audience, which it should have. And thank you again. Thank you for sharing your work.
Thanks.
Thanks, Divine, for being here. Thank you. See you soon.
Thanks. Bye-bye.
Bye.